Hello, everybody. Make sure audio is connected for everybody. Excellent. Well, welcome to October's Roundtable. Apologize for being a little bit late here. We were having some technical issues, so glad to see all of your faces. As a reminder, this is the discussion and not a seminar. You can turn your video and your audio on and off. We really would like some participation. That's really been our goal when we started these roundtables, was to encourage lots of individuals to engage in these. And while we have our panelists who are ready to talk about the different topics, we would also love to hear from new people. So we're not just the echo chamber. We already talk enough to each other. So we are recording for possible future use of MOPA. So just be aware of that. And the opinions expressed here are our own and do not necessarily represent the views of any of the Missouri Psychological Association. You can get Category B credits for these roundtables. And so make sure you put your name in the chat below if you would like to get that. And then if you have any questions, email Emily at support@mopaonline.org. And let's see here. Kit, I think your audio's on, just to make you aware. All right, so let's do introductions. I am Chelsea Gillum. I'm a clinical psychologist. I am the system director of integration at Burrell Behavioral Health and the MOPA Integrated Care Chair here. And we have a few panelists today, and I'll let them introduce themselves and tag the next one. So Dr. Thompson.
Hi, Dr. Thompson. I'm the other director, assistant director of integration at Burrell. And I would call myself like a second level panelist. I'm a regular panelist for the MOPA Roundtable, but this is a topic I know very little about. So I'm here to learn and be curious and ask questions with the rest of you all. And I will tag Dr. Liu.
Thank you, Dr. Thompson. So I am currently working as a behavioral health consultant and an intern supervisor and a implementer of an integrated care model in a system that we're contracting with. So doing all the pieces integrated all the time. And I'm also a regular presenter for this committee and this panel, and maybe a second tier like Dr. Thompson in this particular area, although I do really appreciate working with older adults and you know, I'm excited to discuss some of the unique challenges, because I think, again, we always bring different perspectives because most of us somehow interact with the lifespan in some way, even if it's we're doing peds and those kiddos live with their grandparents, right? Different kinds of family systems. So I'm excited. Oh, and I'm going to tag my teammate Noah.
Thank you. My name is Noah McCarty. I'm a licensed clinical social worker and a behavioral health consultant with Farrell Duncan Clinic Internal Medicine. So I see ages 18 to 100, and Farrell Duncan falls under the Cox Hospital umbrella.
Thank you, Noah. And I'm glad we ended with you, because I have a question for you. So Noah, for those of you who don't know, Noah has worked in our family practice clinic at our Farrell Duncan Clinic, and then actually shifted his role to internal medicine clinic. So we went from kind of more lifespan to older adults. I believe, correct me if I'm wrong, Noah, but that was a rather new experience for you when you made that shift. So you are perfectly positioned to answer some of our questions and also talk a little bit about that experience. But the first thing that I want to ask is, what were some of the biggest differences in that shift from family practice internal medicine? Because I think for anybody here that does see kind of like family practice clinics, they may not, that's the way that we would be easiest to determine what those biggest differences are and like what that would be like to work in that space. I am not wording well today. What are the biggest differences you saw from family practice internal medicine? I'll hand it off.
I would say working with kind of young people, you see a lot of more systems approach. So involving the family, especially the younger the client or patient. Certainly the older folks, it's more holistic in nature. So you're involving the physician a lot, which is not to say that you don't involve the physician or provider with teenagers, adolescents, or adults. But older adults, they require a lot of more medical evaluation to rule out concerns that may not be as obvious. And you kind of need those test results before you know what interventions would be appropriate.
Absolutely. So what was that experience like switching gears from family prac to internal medicine?
It was significant because I feel like in family practice, you meet with, I guess, a lot of millennials, Gen Z, even younger, and they kind of, you speak the same language, especially I'm, millennial myself. So you're kind of on the same page. Adjusting to kind of older folks, maybe 60, 70 plus, you kind of have to learn a new language, which was a challenge, and consider new challenges for them that I hadn't had to consider in treatment planning before.
I'm thinking about, so the internal medicine clinic that Noah's in is also one that I worked in previously. And that was also my first experience working with older adults. And I'm thinking about the behavior change that you have to make between those populations, between an older adult and maybe more like a millennial that you're talking about. What are some of the behavior changes that come to mind for you? And I'll talk about some that come to mind for me as well.
Can you speak more to behavior change? What you're referencing specifically?
So like the first thing that comes to my mind is maybe making them comfortable in the room, or even shifting how you behave in the room. I felt like some of the biggest changes that I saw was like how I interacted was completely different.
Oh, I see. Yes. I feel like with like younger patients, it's definitely you're more casual about it. I don't know, just your body language is different. Whereas with older folks, it's almost like unconsciously I'm kind of more formal, more straightforward. There's not as much lingo, kind of like slang that you would kind of reserve for younger patients, certainly.
Oh, I like that. Yeah, using psychological and medical jargon is not advised, right? One of the things too that comes to my mind is that I would establish respect pretty immediately in those rooms. It was different. Like I might ask, what would you prefer to be called as far as your name? And then I might use Mrs. and Mr. in front of that. And so there's kind of a change also in introductions. And while we might do that, we would do that to some degree with our younger folks. There is a weird level of kind of respect that you establish right when you walk in the room that's different as well.
It's interesting too, Chelsea, because I think that can be different across even cohort groups, right? So if we think of older adults, I don't know how many of you have heard this phrasing before, where we have our older adults and then we have our old adults now, right? Because well, I mean, because people live so long, right? 65 is not the same as 97 developmentally, in terms of daily expectations, in terms of what healthy looks like, right? And so even within geropsychology, for instance, we still may be talking about different cohorts. So part of what I'm hearing is that whatever generations we're coming from, naturally, because I can very much relate to this, all of us assume a little more formality when we're working with older adult patients, right? Whether that person is 65 or 85. There's part of us that internally shifts culturally to say, just automatically, this is how I think and believe I will create the most rapport, I will be taken seriously, I will be heard, I will be able to align with this person in the room, right? Versus a much more freewheeling style that I do with my 17-year-old guys to make sure that they're with me and we're going to be doing this together kind of thing, right? And so even within the Vietnam generation versus the greatest generation, you're going to have even different expectations potentially.
I like that idea of like formality. So I'm thinking 100% yes, it does feel like you take a more formal approach. And I'm also thinking that on the flip side of that, your title becomes more informal, depending on what the patient necessarily is seeking. So I kind of talk about this in a presentation that I do every year, and so it's on top of my mind because I just did it. But with our older folks, more often, It's important to let your title be more fluid. So the physician who may have been seeing this patient for 10 years and has great rapport with them might say, one of my friends is here in the clinic and I want you to meet with her. Versus maybe she knows that patient really values the labels like doctor. And so she might say, there's another doctor though. And they're like, oh, okay, whatever that means to them. And so the physician in all of our spaces, that's true. But I do feel like that's almost even more so in our older adults, that becomes much more fluid. Any thoughts
No,
on that?
I think, part of, I can definitely relate, Dr. Gillum, in the sense that I think when physicians have been treating or carrying a particular patient's care for so many years, they have a different relationship that is very unique. And as we all know, regardless of the setting or the age that we're in, how the physician or the PCP or the primary, where the referral is coming from, how that person introduces us and works with us is going to potentially make or break the initial openness of the patient to talk with us. So I like that you're seeing providers who are adjusting to their patients, right?
And pediatric psychologist here, I can't help but notice the parallel.
I was going to ask you that actually, because I think there's probably a circle here.
100%. So when you're working with 7 and under in a peds clinic, I can't tell you how many times I got referred to as my friend or Dr. Kristen, right? Because those are the things that feel accessible and non-threatening. And you can call me whatever you want to call me if it makes me feel more approachable and not threatening. But I think it speaks to the developmental needs on both ends of the spectrum to feel safe and understanding and be able to have this match with the schema that you have. It feels very familiar hearing you say that.
I think it'd be very different.
The other thing that comes to mind is rushing, making sure that we're not rushing in those appointments, which is also probably another parallel, but speaking in a slow, normal tone. And we want to speak deliberately, not necessarily louder. So while your tone might sound louder, it's not necessarily that your voice gets louder, because that can sound actually really aggressive. So it's important that we speak more deliberately and not with a high-pitched tone, because those are actually more difficult to understand. You keep your hands away from your face so individuals can read lips. You sit facing them. These are things we should consider, right? Like hearing impaired, hearing deficits, and also visual deficits. What's the lighting like? Can they see me really well? Am I close enough? Do they have their glasses on if they wear glasses? Should I ask them if they would like to get those things out, because they might take them off for a physical exam? And so those are things that I think are very unique to this population that we have to be aware of when we're walking in that room. It's different. Your behavior is different.
You mentioned tone and it's so important. It's really like you're framing the room before we get into, like, you're framing kind of the context of how we will even be with this patient. I think there's, we know it, and yet it's so important that it's worth mentioning. Slowing down does not mean talking down to somebody. And we often do that not intentionally, right? We think that because, legitimately, normal aging includes processing speed decreasing, right? As Dr. Gillum already mentioned, sensory experiences decreasing. And so we want to be able to convey information clearly, succinctly, in a way that the patient can perceive. And yet we want to be cautious about infantilizing them. They are adults, right?
That reminds me about the language that we use. We want to be careful about what words we use and how that might be interpreted differently with different generations of people. So dementia, for example, that word might, for them, feel like they may hear insanity. And so being aware of what is that interpretation of that person also probably parallels with pediatrics. Cancer may mean death sentence. How do we gently talk about some of these things when we know that there's preconceived notions about those, and the generation they grew up in, medicine, it was not where it is now. And so outcomes were different, and they still may remember the other outcomes versus the reality now where they really have great treatments that work in some spaces. Taking notes for them, that comes to mind too. It's really important to write down what it is that you'd like them to do, any highlights, any follow-ups that they need to do, writing those things down, but also making sure, checking on literacy and whatnot. But instead of just assuming that they're going to remember that information, that is probably one of the more common things that a new BHC in a geriatric clinic or an internal medicine clinic might do, is that they might give them verbal information and not necessarily take notes for that patient. What am I missing? What other things are different?
I don't think this is always different. Excuse me, Noah, I'll be quick. I think it is important to note that many more elderly or older adults than we would prefer do live in poverty and live on very limited incomes, and may not necessarily say that to you directly or in those words, but remembering that in terms of what we're asking for in terms of follow-up medications, being open to problem solving and ensuring that they have the ability to follow up on what we're saying. Because finances can be very tight on a limited income, and older adults are disproportionately affected by higher poverty levels in this country. Just could say more, but I won't. Noah, go ahead.
I just was going to comment on something Dr. Gillen mentioned about diagnosis, kind of the words we use. I had a patient specifically who was diagnosed with dementia, and she refused to use the word dementia. She called it that thing. And so that's what we called it. And we just led with that. The interventions were the same, but I had to get buy-in, build rapport and trust before we could even approach that word. And we incorporated a lot of family involvement as well, kind of regular contact with them with her consent. And eventually she came to, a place where she could use the word. And we, and that took a lot of work on kind of adjusting expectations. What will your new normal look like? So on and so forth. Because she did have, like Dr. G mentioned, preconceived notions about what person with dementia has. Like she's worried about the prognosis, and there was a lot of uncertainty, and that word meant all of that to her. So we had to change the word, and we, it's not so much we allowed her to do that, we encouraged her to do that, because eventually she was able to, identify with it and say, okay, this is what I have, and I'm in a better place with it.
Such good patient-centered adjustments, right? Like we're talking about the same thing. I mean, with adults, I call their internal voice a bully, or with kids, we'll name their depression as something external, so they can externally work with it and fight with it. So I like that you were able to help the team accept that this is how we're addressing this for her comfort, so we can still implement care. Yeah.
And it helped having the providers on board. So we were all on the same page. So I wasn't using, kind of a synonym for it, and they were using dementia. We were all, we believe that patient care was important, and language plays a part in that. So that helped a lot. I think it would have been way more challenging if it was only me trying to do this.
Agreed.
I just thought of another one. Make them physically comfortable. So if you go in the room and they're sitting on the exam table, offer to them to sit into a seat where their feet can touch the ground for better blood flow. That's for everybody, but especially our older folks, is if they are maybe much more comfortable getting off of that table, and then offer to help them get off the table. Stand really close when they do get down. Like all of us have gotten off those tables and probably almost fallen. So make sure you're also just providing the extra support. Almost. Yeah. And then do not interrupt. I read a study a while back that said the average time frame before a physician interrupts a patient on average is 18 seconds. Which I don't know if I was shocked or not, but it was 18 seconds. It's a shocking number. Don't be that.
Can I add to that?
Yes.
I think on the other side, because it can help, I think it can help us contain our anxiety to get information, right? Absolutely. I mean, interrupting within that first 30 seconds is, gosh, that could shut a person down to talking, right? So I find some relief in knowing that the literature has also shown that the vast majority of people, I'm not talking about, somebody in a manic episode necessarily, will say everything that they want to say in 5 minutes or less. Right. So like, even if we had to just sit on our hands, like whatever it may be, there's some reassurance that I can allow some space, even in this limited 20-25 minute visit, for this person to feel heard and tell me what their concerns are before I start digging in. So it's kind of like a stopgap on the other side that the vast majority of people are going to fall under.
Absolutely. Any thoughts from anyone else in the room before we go to the kind of the next thing?
I think, for everybody that works with this population more regularly than I do, I think one of the things I have always experienced is feeling like I'm not doing enough, because it is my experience has been that everything moves more slowly. You can't say, here's this worksheet, go home and track these episodes, bring it back, we'll talk about it, we'll make a plan. Like, everything just moves more slowly, similar to young children, really. But feeling like, am I being effective here? All I did was listen, and I'm supportive. But I don't feel like I really changed anything. I think I struggle to go, to really check myself and say, no, they needed to be heard here at this doctor's appointment, and they needed to leave here knowing that somebody heard all of their concerns about the recommendations, and they got to like really process it, and that even that is meaningful. But I feel, I don't know, like sometimes I just feel like, am I doing the right thing? Am I not doing enough? And I'm curious if that's been others' experiences, or how you check yourself on that.
I think we often underestimate how important it is to listen to them and how much that means to them. If we think about the amount of loss and loneliness a person is experiencing, and how much listening can do, and also how much listening needs to happen before we can go to the next thing. It's almost like the hierarchy, right? Like, I think that listening is almost like the hallway to get to some of the substance, because there's been a deficit in people that are willing to engage with that individual. And so I think you're right. I think it feels slow because it is slow, and we often underestimate how important that is, because I think for this population, it's more important than any other group. That's my thoughts. What do you think, Noah?
No, I agree. And I think that's something that's maybe not unique to older folks, but I see it a lot. And it's sort of like a systemic kind of socioeconomic thing. Oftentimes, I think they feel forgotten about. Like, children of these older folks will move them in, maybe off across the country, and then they're, once the crisis is sort of resolved, mom's here, she's fine, so now she's okay in her apartment. Their loved ones are dying, good friends are dying. There are numerous medical complaints, and sometimes they don't have many people to talk about that with. So even just allowing them to talk about stuff that may seem irrelevant to the presenting problem, I think that goes a long way to building rapport, and also just giving that space, like, oh, okay, I'm valid. This is okay to talk about.
Noah, what are some of the more common diagnoses that you're seeing in internal medicine right now?
I would say some of the straightforward depression, anxiety. Depression gets a little unique because there's the significant loneliness component that I didn't encounter a lot with the younger folks. And it's like a different kind of loneliness that can be challenging to treat. I do see a lot of memory impairments. That's probably the bulk of what we treat here, as well as kind of the ADL type stuff, and there's a large medical component that required a lot of kind of ongoing training on my part, but I'd say those are the ones I see a lot.
I'm thinking of the 3 Ds that you have to be able to differentiate between depression, dementia, and delirium. And that comes up quite often. And so there are some, for those of you who don't know this, there's some fantastic charts online if you search those three that will differentiate between them, but that comes up routinely. And delirium, more specifically, is often missed, and it's often misdiagnosed as depression, even though it has a pretty difference in presentation. And so for a lot of medical providers, there's not a lot of training in depression even, and anxiety. And so it can look like a lot of different things. And so once they rule out some of the medical causes for certain things, what you'll see is a lot of just depression. And it may be some very different things that we are actually need to pick up on and alert physicians to.
Yeah, that super sudden onset with delirium, that tends to be much more acute. And yet, it's just interesting because there is such an overlap. And I think training about like late life development can be limited in many different professions. I think across fields, like historically, I'm a psychologist, we like in healthcare, a lot of times we will attribute changes that may indicate pathology, we attribute them to normal aging. At least that's been historically more prevalent, that we kind of assume, because yes, it is simultaneously true that as people age, they're going to have more loss, grief, bereavement of actual relationships. Often they're also processing the life changes and the loss, maybe in independence or end of life issues. I mean, we can get into the kind of common presenting concerns, but I think it's important to remember that there is also healthy aging, right? So Chelsea, how do we help providers differentiate what's going on? Because the treatment is going to be different. If there is psychopathology, it's going to, treating a UTI is very different than looking at long-term cognitive decline, right? And then often dementia has that prodrome of kind of depressive type behaviors for up to a decade. Like they're so sticky and icky. And we have to be simultaneously cautious to not overlook it and minimize it as natural, but also able to help with differentials for sure.
I'm thinking too, how often people assume that depression is a normal part of aging, and it is not. And so the assumption is they're old, so they're depressed because they don't have these things that that they're ill, or they don't have as many people, or they had a loss. Depression is not a normal part of anything. It should always be picked up on, it should always be assessed, and it should always be treated. And if we continue to assume that that is just a normal part of being older, not only are we discounting just some wonderful experiences that older individuals have with our assumptions, but we're going to miss significant risk. And we'll talk about that. Suicide risk is very, very high. And so we have to make sure that we're keeping our own biases in check as well. Noah, sorry, you were about to say something.
I was going to comment on what Dr. Litt had said as well. I think having corroborating information can be helpful. So incorporating the family, getting consent to talk with, the children, the grandchildren, spouses, because I only often just meet the patient, and I want to see how do they function at home, how do they function when they're out and about. That helps with a lot of case conceptualization as well.
So I think that plays into here what Jen is asking too. I love this question. I'm curious what assessments other folks are using, and then how folks are discussing memory care with older adults, especially mild memory cognitive concerns that can be many different things. So as far as screeners, we use slums a lot, and something I've advocated for that I've not seen happen yet, but I would love for it to, is actually on those Medicare wellness visits, that's when you start the slums, and the slums is given every year after that, so that we have a baseline. Are we going to pick up much usually on that first Medicare visit? For most people, no, but for the ones we do, that's huge as far as longevity and treatment. And so if we don't have a baseline, which we often don't, we often are handed individuals where there's already significant concerns, and then we have a not great slums, but we have no idea how rapidly they're declining. No idea. We just have a number and we know it's not great, and it doesn't give us a lot of information about treatment. So I would like to see screeners given earlier and given consistently every year and charted. And I don't see that happening in the spaces that I'm in. I'm curious if other people see that in theirs. And then to Noah's point, we absolutely want to include the family. So anyway, if we catch things earlier, also those conversations are a little bit easier because they can see the decline as it occurs and they can ask those questions. It's not a shock. So that's part of it. But also we have to include the family in those discussions. So if we can get that collateral information and figure out what their support system looks like, sometimes that can be a much easier road to kind of navigate than if it's just us and them, and that can feel really scary. We should not give people information that could be really, really scary without first identifying that they have support at home and ideally with them in those moments. And so that's something to think ahead on as well. Noah, I thought you were going to say something too. Sorry. Every time you turn your mic off, I say something.
Oh, well, I'll Dr. Gillum, I think what you were saying about catching it early is important, establishing a baseline. Maybe if a person has a yearly Medicare eval or, whatever that may be, yearly physical. I think a piece of that catching it early is obvious that we do not yet have any treatments that reverse dementia. We have some medications that will sort of stop certain neurophysiological processes and sort of slow the process. However, in this case, obviously prevention, as silly as it sounds, doing the Sudokus, finding the different actual cognitive exercises to try to stave off cognitive decline is going to be a much easier route than trying to cope with significant decline.
And I think doing something like the slums early would help normalize the experience. Because whenever I'm doing it, like Dr. Gillum said, it's like there's already suspicion of memory loss. Usually there's the patient's fallen, the patient's had something dramatic happen. And so now we're doing it along with a battery of other tests. But if we're doing it early, we can say, okay, this is what we're doing, part of normal course of treatment. And then when we do follow-ups, the patient's already sort of prepped for it.
I thoroughly agree. And then some, normalizing it. And, I think Noah, you'd mentioned systems kind of early on, and then, I keep hearing again how much the system is reflected in this. It can be really hard for people to have to shift like life family roles, right? Or especially like a matriarch or a patriarch of the family for a long time. And then we're saying, thank you for your report. Now let me talk to your child to report on you, right? Because their child is an adult and is maybe a more reliable reporter. However, the amount of variability in responses and emotional responses and like family response to what I just said, like I'm going to talk to, could mean so many things and can bring up so many areas for us to do our magic in terms of helping ensure good care, help the patient feel comfortable and in charge of their care. Even if we are getting collateral information, we still want them to feel some sense of a locus of control over their experience.
Yes, so building caregivers into that decision-making process has better outcomes, but at the same time, what you're saying too, and I agree with, at the same time, you have to hold equally the support towards patient empowerment. and giving them control over their treatment plan and life decisions, because oftentimes we include caregivers. Sometimes that can look like that we're handing power over, like talking about a patient while they're in their room to another person and not acknowledging them. Oh, I forgot about that piece. We have to be careful about how we're addressing individuals in the room. It doesn't look like we're not speaking to the patient, we're speaking about them. I
And
said
that
we were
look different for different people. Sorry, Dr. Gillum, just in terms of, you know, our aging population is changing, right? So if we think about the dynamics of the aging population, I don't know what the exact percentage is at this point, but we're heading to or close to 20% of the older adults in this country being identified with some like diversity, whether that's race, ethnicity, culture, et cetera. So we're talking about intersectionalities in terms of treatment, but also, you know, those numbers are just continued to, that percentage should increase over time, you know, assuming trends hold the same. So then we're talking about integrated care visits with family members that may have entirely different dynamics and expectations than maybe a dominant culture that we may have grown up with or are most comfortable or familiar with. I say we as the panelists, I'm not speaking to anybody else's identity.
I'm seeing in the chat lots of chat about the MOCA as well, and I appreciate Jen's comment about using the MOCA, but it not being the best measure for our minority veterans because of the norms out there. And I'm not necessarily familiar with what the issue is there. I'm curious about it. If Jen, if you're able to unmute, or if anybody else here can speak to that, and whether some of the other measures mentioned are more robust or better in that regard.
I mean, I'm happy to, I'm certainly not an expert by any means. I just do a lot of this. And so I'm always looking for like the latest data, because the MOCA can be so sensitive and often overestimate at times impairment that I'm always very cautious. And so I always adjust for things like age and education. And we actually had a researcher at the VA who did a lot of that work. And we have good data to pull from our own population, which I love. But we tend to really get older white males as our primary, you know, comparison group. And so it's just not the best. And I don't use MMSE or the slums very often, but I honestly don't know of a lot of good comparison data for that. So I'm curious if other folks do, because I will certainly switch if it's a better fit for my folks.
The Folstein MMSE has really high specificity and sensitivity overall, as does the clock drawing test. I like the clock drawing test because it does have that, because it's quick, it's easy, and it's not language based entirely, right? I was thinking about this yesterday, though. I was like, what happens when a certain cohort becomes older adults, but they didn't grow up with analog clocks? Like, what are we going to do? You know, that's actually going to be a thing before too long. So those are my quick and dirty thoughts, is that both of those tools have good sensitivity and good specificity. Jen, if that helps at all. I do know somebody mentioned a Trails B in there somewhere, which Trails can, again, even give us better indications of processing speed sometimes, as well as like ability to hold and navigate information. This isn't brand new, but I think maybe a year or two ago, we came out, Phil, you might, Dr. Swope, I don't know if you know, there is a Trails X now, if people are not familiar. So again, it moves away from letters and numbers. So if we're talking about different populations, people with low literacy, etc., it can work better for diverse populations because it takes out that letter.
Thank you for that information. I'm thinking about screeners. I'm curious if anybody is screening for abuse in their clinics, and what that looks like. Noah, is there any routine screening?
Not formally, unfortunately. It requires sort of just somebody with an eye and saying something, or, primarily informal.
We know 8 to 10% of elder individuals experience abuse of some kind, which can also be financial exploitation. So it's also, when we talk about including caregivers, also being aware that there's also a lot of abuse that occurs, and making sure that that individual is a safe person to talk to as well. And I'd say that's probably underreported significantly, and it's still 8 to 10%.
Yeah, I think considering something like spousal abuse, I mean, generationally, our views on spousal abuse have changed over time, what we consider abuse. If you have somebody who's 70 plus, they might value something over kind of like something like commitment, dedication, and to them that's not abuse. Like, well, it's just something you put up with when you get married. So you have to navigate that cultural, I guess, consideration as well.
You know what I've heard a lot, because when I was working in internal medicine, there was a lot of individuals that disclosed intimate partner violence. And we know that some violence comes with some cognitive decline as well. So if you have two individuals who are older living in a home, there's probably an increased risk of that. But what I heard from the treatment team often that shocked me was, they're not going to live much longer. Why don't they stick it out? And that always struck me, but I heard it consistently. I don't have anything else after that. That's just going to sit here and let that sink in.
I'm going to make sure I heard that correctly. Because I don't know if everybody's quiet because they're in shock, or like I am, or if we're just quiet because it's lunchtime. That was a provider response for you?
That was a frequent provider, and also like adult child response.
So the kind of lack of understanding, awareness, ignorance about the suffering, or like what may actually be happening for that individual, and kind of minimizing it.
Yeah. And also in trying to navigate that, resources for helping an individual get out of a situation like that when everything has been combined for 55 years is incredibly difficult. Along with lack of access, like how do you physically move an entire house? How do you split everything that you possibly have? Are the children are concerned about wills and whatnot, and the family gets involved. It is a mess, and so that's something to be aware of. Just if you're in an internal medicine clinic, I want to make sure we hit on also the high prevalence of suicide, which is often not talked about, including silent suicide, which is just stop eating, not following medication regimen. Those types of things. I talked a little bit about this when we did an eating disorder roundtable, and because silent suicide often comes up around that, because anorexia is a really common way for individuals to take their life. And so I'm curious if anybody has any thoughts on that. But statistically speaking, silent suicide is almost 100% effective once a person decides they're going to engage in that. And it often looks as if there's no overt reason that it exists, so it's often not picked up on either. And then weight loss is looked at a normal part of aging, which is not necessarily true as well.
To some extent, the balance between autonomy and like personal autonomy to make decisions, and where and how we can intervene holds true, right? Like we come across similar considerations in terms of, and maybe even slightly more complex iterations of this, because a common method of wasting, self-starvation, is not prevalent in the other like age population. So we're kind of dealing with something differently. So how do we describe imminent intent when we don't know what exactly what the next, which meal is going to be the one, I'm being a little bit silly here, but not meaning to make light of it, meaning to say it's so nuanced, it's almost silly to even try to conceptualize like an imminence there. And then you start to blend with end of life issues or like terminal illnesses where, talk about hard things that other family get pulled into and asked to do and be witness or be a part of, and where and how are our legal, ethical ramifications, implications, behaviors. A part of that, I do want to remind everybody that if it is helpful for you in your work, the APA does have specific guidelines, aspirational guidelines for working with older adults. So that's just a reminder. And I tell almost any person or family I deal with that has grief on the table or loss, this is copyrighted, that people get weird around death. Like systems go wild. Like they go wild. People are like, mom gave you that candle when you turned 30 and therefore I should have this piece of like these. Noah, you know what I'm talking, because your laugh tells me, the reactions and the responses, things from way back when, and it's such a life transition that the whole system is thrown and people act in ways that they don't necessarily normally act. And I think some of that circles back around to the caregivers that we were talking about, like caregiver stress on family members and the burden of caregiving can be extremely heavy and extremely stressful. And some people will really jump into that role full force and it kind of takes over. And those people can be more likely to then have stress reactions, etc. So things just get messy at times.
I have a question, like with the suicide and also circling back to abuse, it's reporting. So, I think it's great. The example of domestic violence, when is it domestic violence, which is problematic, but not a mandated report? When does that become a mandated report? Because it's elder abuse. I know self-neglect is a reportable category for elder abuse. And so is intentional wasting, silent suicide, do you report that as self-neglect? If you're a mandated reporter, do you have to be reporting? Like, I feel like I'm just so less sure about all of the reporting elements with elder abuse. I'm curious if anybody can speak to that clarification.
That's totally reasonable because reporting on this is nuanced and difficult.
Well, and I think one helpful thing to remember is that adult protective services, I know they have different monikers, function similarly to child protective services in the sense of being, if you're coming to them with a true legitimate concern, right? It's not out of malice. It's not out of punishing the kid that you don't like how they're treating it. Like if you have legitimate concerns as a mandated reporter and you go, they're ultimately going to be the ones to say whether or not that meets the threshold. So as long as we're coming in with our best professional intentions,
I have found that they react quicker and more consistently than the child abuse hotlines. So, and they will have a dialogue. It's very much like, what's going on? Tell me the story of all the things. And it's not like, do you have this? Do you have this? You don't have that?
Yeah.
Nothing I can do, which is how it felt oftentimes when I would report child abuse. With the older adults, it might be like, I don't know what I'm supposed to do with this. They have a sore on their leg and it's infected and they're not coming in. And also the person that lives with them is not bringing them in. And I don't know if I need to call or somebody needs to check on them, or there's hoarding in the house and they're tripping. Like those types of things, you can be real flexible and just ask them to go check. And then what I've found is that they go to the house and check and then report back what's going on. And so I found that system to be fantastic and utilized it a lot.
This is maybe not a great 1255 question, but an ethical question of self-neglect is reportable. I'm a mandated reporter. and somebody who's 97 and ill says, I'm just kind of done, and I'm not eating. And where is honoring their wishes? Where is I'm a mandated reporter? What do you do? I mean, like, I'm not saying I'm going to be the BHC assisted suicide, but at the same time, like, at what point is their autonomy differentiated from their self-neglect?
Right. That is the question. I mean, it's similar to what we would talk about with any aging, like the dynamics of that balance are going to be similar than with any population, which is why that the imminence is hard to establish, and it's tough. So I want to throw out one thing if others don't have it quick, because I know we're getting towards time. I'd mentioned to Dr. Gillum before we got started that I was looking through some tools, and she came across the same tool, and it's pretty neat. So I'm going to put it in just the name of it in the chat. I was hoping to get a link, but I think this is a little bit fun. It's called the Pikes Peak Knowledge and Skills Assessment. It's for like older adults, or I think they say for geropsychology or something like that. But it divides all of these domains of care that, maybe would be most appropriate for specialty mental health care, but like we have to know everything that specialty does and be able to condense it for our environment. So it talks about different competency areas for working with older people, like knowledge of development, and then breaks it down into specific skills, almost like any other kind of evaluation, like for an internship or for a competency, in terms of what's normal aging, what are the common medical illnesses that you're going to see, what are common end of life issues, what are reporting issues. So if you have an interest in looking at where you might want to brush up or where you need to supplement for yourself, I thought it was a neat self-reflection and a good reminder. So I just thought I would throw that out there in terms of being able to know what interventions and knowledge we need as well, kind of a self-check-in. And I think, Dr. Gillum, to your point in the chat, and coming back with you, Dr. Thompson, with how do we report, sometimes physicians have different reporting than we do. So like we don't report interpersonal violence per se, and I'm pretty sure physicians have to, some or are mandated to. I don't know all provider specialties.
All right, that wraps things up for us. I will tell you, on October 21st, there's an ethics-focused webinar on the trust called Perplexing Problems in Psychological Practice. Say that 10 times really fast. That's a 6-hour Category A credit. And the next roundtable is November 3rd, and it is on perinatal patients. So we'll be, Amanda, be reaching out to you. Thank you all for being here so much, and I will see you next month. Thanks to our panelists.
Thanks, everyone. Good to see you. Have a great day. Bye. Hi, Mark. Bye. Hi, Dr. Thompson. Hi, Noah. Bye, bye, bye.